Now I invite Dr. Prasad sir for his talk on my tips for successful TKA.
Or color mic nahi hai. Okay, hi friends. I know it's quite late in the day and still we have got a lot of topics. So my talk will be only just some points to ponder, nothing more than that. ध्यान दे दे और किससे आपका बढ़ता है यार हम तो ऐप पर चलो so I just want to know that we still want to have a happy patient. Why we should have a happy patient? This is a patient which I operated. Unfortunately, I lost one last year, but after 25 years of survival, and another is 21. You can see I was a cruciate retaining surgeon. At the end, I changed from LCS to the PFC group of implant and changed from cruciate retaining to cruciate sacrificing surgeon. And I don't have any regrets anyway. So this is how it works. So patella, I was using patella vachan, now I'm not using a patella vachan. So this is all the changes I have done. And this is a patient, left knee still surviving, still surviving patient, 26 years and going strong, 91-year-old. A Apollo knee done in Varas, and you can see the stem is a little, some slope, but again cruciate retaining. Another knee I did a PFC that was done in 2002. So again a good follow-up. The idea is, the patients are going to be there. The knee replacement is a long surviving surgery now. So what you do, you have to make friends. And it's an old thing which I quoted with Dr. Wakankar yesterday. By Leo Whiteside, I heard it in the talk. You cut them, you marry them. The joint replacement is a surgery where you want your patient to be happy. Otherwise, this lady patient lives almost 2 kilometers away from me. Her bungalow is there. Big lawyer. So all the recipe for disaster if she would not have been happy. So every patient, we have to make them happy. So don't try to think. We all know the concept. How we execute them, that is important. What does the record say? 15 to 20% of patients are unhappy. Why they are unhappy? There are one determinant of satisfaction, which are all patient-related factors, which are expectations when doctors give them a lot of expectation. Maybe the joint was so bad, the soft tissues are not good, then psychosomatic issues are there. But the important thing is, there are another group of factors, the components of satisfaction, which are the surgical skill. And I'll be talking about only these things now. Number one, choose the exposure. Choose whatever exposure you choose, they all give good results. But try to minimize the muscle injury. That is very vital. How you do it, you decide. You can work with people. Nafasat se kitna kaam karenge, that will protect your joint, that will get you good function. I do subvascus, I routinely do midvascus now. It's very convenient, but one of my juniors was in the OT, he said, I've never seen subvascus. I'm like, go ahead, I'll just do it now, right now and show it. So yes, it can be done. The only thing I cannot avoid the patella in this subvascus, but I can do when I've done all the cuts. So handle with care. Soft tissue handling is the key for good post-op function, reducing the chances of infection and edema also. Very, very important. Cut bone only that much so that you know the thickness of the implant you are going to apply. Only cut that bone where you will be able to reproduce the joint line. Joint line reproduction is the key to a very good functioning joint. Remember, and learn to play based on the position of the patella. Sometimes you can do them a better favor by altering the joint line also. And this is an example. I was doing it totally in a fracture case. Definitely the condyles were gone. I thought, old lady, why I'll do anything? I went for a sleep. But when I'm using a sleeve, I can't have a simple flat tibial surface. The surface looks flat. I use the sleeve so that I can elevate the joint line of the implant so that it matches the meniscus which is there, which is the joint line for the tibia, all femur. So check every step and cut. Nothing to say, it's very paramount importance. This is our robot. Robot is there to verify things. My computer navigation does the same. But you have got tools. A marking pen, a rod, a measuring device, a caliper. All these things are robots in our hand with our brain. You must verify whatever you're doing and keep on verifying. A single misstep which leads to a compounding of the fallacies. So friends, this is very important. Even when I'm using a computer navigation, I've used a robot, I will cross-check manually with my eyeballs. Well, it's going fine or not. So reproduction of the joint line is important. So if there's too much of erosion of the bone, we'll be doing a replacement with 9 millimeters. Still we'll be elevating the joint line. So remember these simple things, keep it in your mind, and then try to do the bone cut. Maybe there's less bone cut. It may be 7 millimeters, not 9. Always check. Once you cut proximal tibia, distal femur, check the alignment. You can check again with the rods. Very simple, old technique, but yes, it is doable. So keep on checking all the cuts before you do. Osteophyte. We all talk about removal of osteophyte. They are very important because small osteophyte is small. Left at a critical point will lead to an unhappy patient. Remove well, cut it, remove it. I'll just flash the slides. And it is what I believe and practice. After cutting the bone, the osteophytes become more visible and then we can remove that osteophyte better. Because there's a white line of the original bone and what extra bone we have got. So that is one thing which can be done easily. But osteophytes are very critical, and not only medial osteophyte, also the posterior one. Sorry. The posterior osteophytes are very, very important to have a good painless knee and good functional knee for the patient. Patella, whether you do a patella resurfacing or you don't do. Remember, you have to do it well. Patelloplasty is very important. Most of the pain has been attributed to the false patella. Whether it's a mild trucking patella or a osteophyte left there or the button applied at a wrong place. All these things do create an unhappy patient. So remember, these small details you must have in your mind. This floating patella is definitely not leading to a happy patient. The other knee must be good, but this knee is not. And the critical thing at the end, I will say, it's the balancing. Balancing is very important when you do with trials. Ensure that your trials do not budge. They should not move when you're doing extension and flexion. That only says that you have done a very good trialing, and then you can go for cementing. It's very important to see in all the things, there's no mid-flexion instability. And if at all you have got a pinching sensation, I think be brave to do a freehand slicing or adjusting of the bone. You don't have to be rigid to 3 degrees or 7 degrees of slope. You can adjust according to the patient, but be judicious, and you can always use a freehand to get a better balancing. And this is what the balancing should look. I'm sorry, I'll try to show this video again, if it can. Yeah. So I'm very rigid in accepting anything beyond that. It has to move fast, and the patella should be absolutely sitting there all the time. And that is how everyone must try. Then your patient will be going upstairs or downstairs next day of the surgery. I can assure you, if the quadriceps function is good, it's balanced well, your knee will do well. So try to create a happy patient. That's very important when you're doing knee. Here, there's nothing like remodeling which is going to save you. You can leave 30-degree angulation, it will be all right. But there's nothing to save you from that. Do it one time, do it well. Thank you. Thanks a lot.
Thank you for the very illustrative talk. And I think the next speaker is, Dr. Vijay. No,
Dr. Vijay. Yes.
Dr. Vijay Kumar.
Dr. Vijay sir, please come on this stage, and he has to speak on UK relief video presentation.
Okay, so after PS, CR, knees, so I'm going to speak, I'm going to in fact show you a small surgical video regarding partial knee replacement. So partial knee replacement is also a very successful surgery for those who believe in it. An ideal indication is an anteromedial osteoarthritis of the knee with an intact ACL and a pristine lateral side. So I think, yeah. So it's a mini arthrotomy that you do. You see the lateral side first. This is an Oxford knee that is being shown. You see whether your ACL is intact or not. There is an ACL hook. And after this, you take out the fat pad and then on the medial meniscus. Then you make, you clear this osteophyte on the lateral side so that it doesn't impinge. And then you mark where your vertical cut is to be in direction with the ASIS. So this is how your, and then you have these spoons. So normally it's a small size for females in India and also for smaller males, and it's a medium size for a larger male. And then you put on this jig. This is the jig which is used to cut the proximal tibia, and it gives you a slope of 7 degrees if you put it in between C and E. And once the jig is clamped onto the ankle, it is then connected to the spoon, which is a 0 mm spoon, which will give you a space of around 7 mm for the bearing and the tibial component. And it has got a G clamp, which comes in 2 sizes, 3 and 4, so it is connected to that. And this it is then pinned on to the tibia, and then you do the vertical cut first in direction of the ASIS, that's for the, and then once the vertical cut is done, here you have to be careful not to lift your hand or cut the posterior condyle. And then you do the horizontal cut. Be careful not to damage the MCL at this stage. Then you take out the tibial biscuit. Once the tibial biscuit is out, you need to measure it. So this is the hardest part, to take out, the tibial cutter and taking out the tibial biscuit. Once this is done, everything is same. So that's your tibial biscuit which is around. So normally you remove around 2 mm of bone. Then you can size it using the template on the other side. Then your feeler gauge of 7 mm you should be able to go in the gap. You have recreated your friction gap. Then you open the canal. Once the canal is opened, you put in a rod inside, and then it is linked to a jig for making the pegs for the femur. So it's all a linked system. It's the microplastic system which makes the surgery very easy. So you mark the center of your femoral condyle where your pegs for the femoral component has to be there. Then you put on this jig and you link it to the intermedullary rod. Once it is linked, so you will be able to make 2 holes, one smaller and one larger, for the pegs of the femoral component. Okay, and it has got the outline of this is same as the femoral component, so it also tells you where your femoral component is going to be there. So you can do minor adjustments here before putting in the drill inside. So it should be in center here. You put in the drill, the smaller one first, and then the larger one, I think it's the 6 mm one, the second drill. So once you have it in, you take out both of this, then you have made the holes for the pegs of the femoral component. Right. Once this is out, then you put on the jig. There's another jig which is there for doing the posterior cut. So you snap on that, that jig. So this is the one that goes in. You put it in, and then using the saw, and you have to be careful there doing the posterior cut that you don't damage anything posteriorly, and more importantly, the saw blade doesn't skive. So you need to tilt your blade a little, as I'm doing it here. So here your posterior cut is done. So your flexion space is now made. So that's your flexion space which has been made. Now you need to make the extension space. So here it is done using mills. So you remove this bit of bone which is equivalent to the posterior condyle of the component of the femur for uni. Then you put on this spigot. So the initial spigot is a zero spigot. This just shapes the femur so as to accept the trial. So you can be sure what your flexion space is there. So you have a single peg femoral trial which goes in now, not the double peg one. So there's some amount of bone left on both sides that you need to take out. Then once this is done, so you can measure your tibial cut on the other side. This can be done on the back table, so you know what size of tibia you are aiming for in the femur. So both can be used interchangeably. So you put on the tibial template there, put on the trial femur. Now your flexion space is made. So now you have certain things which are called as feeler gauges. So so this should be at least 3 mm. So the smallest size of poly is 3 mm. So at least 3 or 4 mm. So it should not be very tight. So this is the 4 which is very tight, but the 3 was going easily. So the flexion space would take in a 3 mm poly. Then you measure your space in extension, and normally you will not be able to put in anything. So it will be around 1 mm. So you need to make around 3 mm or 2 mm of space distally for the distal femur. So again, using the spigot, you can again mill and make around 3 mm of space. So you have equal space on flexion and extension. Once this is made, this is the mill. So this is the most beautiful thing about this. Then there's a collar bone which you have to remove, and then you have this anti-impingement guide which you need to snap it on so as to remove bone anteriorly and posteriorly. This is very important because it's a mobile bearing design. If you don't remove this impinging bone, the chances of polydislocation is there. So you have this mill which goes on and makes space anteriorly so that the poly doesn't dislocate. And you have a posterior chisel so as to remove any osteophyte or bone posteriorly. So even after that you take out any osteophyte bone, then you take out the meniscus once enough space is there. So the medial meniscus with the rim intact attached to the MCL is taken out. So now your spaces and everything is made. The only thing which is left is the tibial preparation to be done. But before that you need to do a provisional trial. So you again do a trial, put in the tibial template, put in the double pegged femur trial in, and now you can do the trial using the trial poly also, not only the feeler gauge. So you initially start with the feeler gauge, see the gaps are equal or not in flexion and extension. So both 3 mm should be able to go in flexion and extension. Then you snap in the trial poly, and then you see if there is no impingement anywhere and the poly is going back. So pretty much your operation is over by this time. Just one important thing that needs to be done is, so here you see the poly should not be, impinging on the anterior bone there, right? This is one of the most important steps. And the poly is rolling back. So once that is done, you then prepare your tibia. So you put on your tibial template, pin it with a single pin there, and then you have a keel saw, which is for the keel. So you have to be careful doing this. After putting in the saw, you have this dental pick or toothpick type is there. So you take out the bone from here. So everything is done. Now you do the final trial with the trial component. So this is the trial component which is going on rather than a template. And then you put on the femur again. So you have to do 2 or 3 times trialing. Unlike TK, only one trial is there. So you put on again you have to see your gaps, because sometimes while preparing the keel is not prepared, so the tibia might be uplifted. So you do again trial using the poly. So now the trial components are in, and pretty much the only thing that is left is cementing to be done. Before cementing, you make some holes in the femur, and then the cement here on the component to be applied, this is the cocktail which is going in, is very, very little. So very small amount of cement has to be applied, both on the tibia as well as on the component. So you put on the cement on both sides, and initially when you're starting, you can cement both components separately, but later on, once you get experience, you can cement both of them together. So you cement the tibia first. This is an instrument called as a microscope, so as to hammer the tibia in. So here the other important thing in uni is always use a light hammer, a toffee hammer, not the TKR hammer, because the bone is very soft and you might otherwise fracture. And then you put in some cement in the 2 holes and on the femur, and then you put in your femoral component and hammer it in, and then put on let it compress using Using the feeler gauge, suppose if you are aiming for 3, so you compress with 4 so that your 3 poly goes in easily. Right, remove the extra cement and hold it around 30 or 40 degree of flexion, not in full extension. Right, so this is how, so you have to wait till the time the cement is set, remove the extra cement, whatever is around that, and then do another trial, see if it is tracking properly or not, poly, and then you can remove this poly. It should be loose, it should not be very tight. If it is tight, then you might have a lateral component arthritis, so that's the real poly which is going in, which has got entrapment anteriorly also. And this is pretty much the surgery has been done, and after the surgery is done, you should see that there is no impingement and the poly is tracking posteriorly in flexion. I think that is it. I thank you. So this is the post-op X-ray. And last of all, I would like to invite you to our annual meeting, which we will be having for around 24 years now, which is the current concepts in arthroplasty. So this time is the last week of July. I invite all of you for this meeting. Thank you very much.
Thank you for a very nice demonstration. And the next speaker.
Yeah, there is some change in the program. Dr. Pushkar has to leave. So I invite Dr. Pushkar for his talk on defect management in aseptic revision knee replacement with video of sleeve. Dr. Pushkar.
Sorry to interrupt your tiny unis with my massive revision. All right. So I'll be talking about metaphyseal defect management in revision TKR using sleeves. These are my disclosures. They are relevant for this topic. So why is defect management a problem? It is because the number of primaries are increasing and everyone is doing primaries now. So there will come a time when they all will require revision. What is the pathogenesis of these bone defects? The basic instability, or who knows what comes first. It's like the chicken and egg situation. So it's basically a vicious circle between instability, polywear or third body wear, and a loosening or osteolysis. This is a landmark paper by Morgan Jones, which doesn't cite any data at all, but makes some very good points regarding fixation in zone 1, 2, and 3, that is near the joint, metaphysis, and diaphysis. So the aim is to secure 2 of these 3 zones in both femur and the tibia. So this is my case. It's an 86-year-old male, multimorbid. Primary TKR was 9 years ago. He has been having instability since 6 years. And there was a sudden increase in pain after a fall. So this is how he presented to us with lytic zones in both femur and tibia and with a fracture in the tibia. This was the CT. I'll just quickly run through it for want of time because we want to get to the surgical technique. This was my preoperative plan. I like to plan all my cases and mostly I also get to stick to the plan. So this was what I had planned, a secured zone 2 and 3 fixation. I'm in this case not dependent on my zone 1 fixation. So let's go on to the surgical technique. So this case is from my time at the Charité. So this is the clinical examination. The patient obviously had instability because of the defects. I use the existent scar. I don't cut it out because sometimes there is no skin left. I use the medial parapatellar approach. I do a limited release and then do a complete synovectomy. Don't be thrown off with this finding because this is common in a third body wear. It is a type 4 granulomatous reaction. When you take off the inlay frequently looks so. And now for the dueling micelles, my assistant and I work against each other to loosen the cement from the prosthesis. So we get a beautiful cement interface and we match the prosthesis to our trial. Now for the tibia, be careful that you don't blow out the tibia out the anterior cortex. So you should stop here and then pull it out or turn it out. Then I start with the starting reamer in the tibia. And this beautiful ruler allows me to ream only till my planned depth. So here is the planning important. Then I ream to my definitive thickness and to my definitive depth. And then I stop. I then use this brooch for the starting sleeve, which is 29 millimeter. I don't know why it's hanging. So this allows me to get a grip into the tibia. I then do that till I get rotational stability. Then I disconnect the broach handle, and then I do my clearing cut with a saw. I do it freehand, but you can also use a guide. Then I put on my tibia plateau, and I lock the rotation in. So my tibia trial is done till now. And then I open the femur. I use the same ruler. It is for cemented with sleeve, without sleeve. So it tells me my depth. I go till I get this finding, a good cortical chatter. And then I take on my my sleeve broach with a size 8 stop for the femur and with augment. I really don't understand why it's jerky. And then I measure the intercondylar width, and the 1/3 of the intercondylar width is going to be my joint line. So I can measure that using this tool. I then do the definitive preparation of the sleeve. I disconnect the broach handle, and then I put on the 4-in-1 block. Under the block comes my spacer. This is for my flexion, just to get a ballpark picture of how my flexion gap is going to turn out. Then I do my extension gap. Latest at this point, you must realize if you need a hinge. So if the MCL is holding at this point, you probably don't need a hinge. Then I hammer on the augments on my 4-in-1 block. This is the horseshoe spacer just to lock in my rotation. After I'm satisfied with it, this is just the step is not really necessary because you've done an intramedullary. So now I lock in my rotation. I put in my pins. Sorry for the video. I then put on my anterior cut guide and do my anterior clearing cut. Then comes the box handle. This pin is variable to miss the sleeve, which is inside. I then disconnect the sleeve from the cutting jig, and then I do my box cut. The chamfer cuts are usually not necessary when you're using 8mm augments like I did right now distally. So now I measure my posterior augments. It's unbelievable. So it's better to put on lateral posterior augments to avoid internal rotation. All right, so that's my box cut. The chamfer cut is not really necessary, but you can do it. Let me just finish this video, a couple of minutes. Then I put on the trial of the femur. I lock it in on those cuts, and then I do my definitive trial run with my insert. So this is my semi-constrained insert, my VVC, varus valgus constraint in attune revision. This step has to be done carefully, otherwise you'll cause a fracture of the distal femur. I've done a trial run, which is sadly jerky in this video. There. So that seems fine. Now you just imitate your trials. You cement the zone 1. You're not really relying on the zone 1. You're just relying on your zones 2 and 3. So you bring it home. In such a big revision, I usually cement tibia and femur separately. And now comes the rotating platform inlay, which is sadly always the case with the sleeve. I don't like it because it causes a medial roll forward. And then you bring your femur home. All right. And again, you extend very carefully. So that was the surgical technique. This is how it looks like post-operatively. Zone 2 and 3 are fixed very nicely. Zone 1 doesn't matter after that. And this is a VVC inlay with the posterior augments. The joint line seems to also be fine. Thank you.
Thank you. I think we'll proceed
All right.
with the next lecture.
Sure.
Please have a seat.
All right. We need to go. Thanks a lot. Yeah.
Now we have talk by Dr. Subhash on tips and tricks of CR knee.